I'll kind of briefly talk about, I know it's a mix of the audience, so, I apologize if this is a little bit repetitious for those in the know, but this is kind of what it looks like to do a stent or to receive a stent. I have recently kind of been interested in trying to do these through the upper arm veins, although traditionally that's been done through the femoral vein, and both work quite well. I usually try to evaluate whether I can do it through the arm or not based on the manometry. So I'll do the evaluation procedure through the arm, and if that was pretty successful and the anatomy was favorable, then I'll know whether I can do that with a bigger system that's needed for stenting. So I use a 8 French short introducer sheath, a long guide catheter that can take me all the way up to the torcula or within the superior sagittal sinus. I use a directional catheter, something that can kind of point me toward the jugular bulb, like a Merritt Brandstein, an advanced glide wire, and then a micro catheter system if needed, if the larger system doesn't get me there all the way. And then I do enjoy the trackability of the Zilver stent, although that's not necessarily available everywhere. The exact stent works quite well. So here's what that looks like. So it's kind of become interesting to be able to use the arm for a lot of endovascular procedures. I think there's been a great adoption of radial approaches for diagnostic angiography, for cerebral angiography, as well as for interventions. And this is kind of the next step within that to kind of decrease the invasiveness and the overall impact. Although, again, the femoral venous approach is really quite safe and reasonable. It is nice to be able to go through the vein when possible, through the arm veins when possible. So usually we're going at the elbow and the cubital vein, but I've done both the basilic and the cubital vein for these procedures. Here's what that looks like. So the arm is prepped out. This is, again, the elbow right here. You can see this short introducer sheath going in over the wire, and that's pretty short. That just gets you into a slightly larger portion of the vein that we can kind of get up with our micro catheter system from there. So I'll show again. So this comes from the right arm. We're going through the subclavian vein, then now up the internal jugular. This is going with a 6 French Sim Select, just in this particular case to pop through the valve, and then tracking that. That's the TrackStar guide catheter. Now taking that guide catheter up in the head. Here I happen to get lucky with enough support, and this was able to ride just over the wire and got this all the way with a little bit of effort just past the torcula. So when you have that kind of purchase with the guide catheter, it really makes it quite easy to get a stent, which can be quite stiff and needs to go through perhaps a few more tortuous areas more proximally. Having the guide catheter all the way through, that bigger guide catheter gives a lot of support. And here I've taken the stent all the way to that point. And so at that point, then I can just pull the guide catheter back. The stent is unsheathed, and then this is what the deployment looks like. So I'll show that in the lateral picture. Draw your eyes down to here. You can kind of see it slowly unfurling. So there you can kind of see the edges of it. It's important to have, I usually keep an arterial side roadmap, usually in the common carotid artery, to guide me, to show me exactly where that point of stenosis is, because if you want to do a single stent, it's really important to center it perfectly and make sure that you don't end the stent in an area that maybe, you get a potential restenosis at. And here's what that looks like in that lateral projection. So in this case, it opened up widely enough that I could actually have the guide catheter traverse through the stent, and you can see that it's really flowing quite freely where it wasn't before. That's what the stent looks like in both projections, kind of coming around the side of the head and down. And I like to do that same cone beam CT venogram afterwards. It's really kind of clarify for myself that I've spanned the exact area that I need to. This may be a little bit overkill, but I think it provides a sense of satisfaction both for myself and for the patient to know this is what that treatment looks like, and we're satisfied with the outcome there.